ONtheGo podcast.
From Greece to Doha, Emmanuel Papacostas, Aspetar Orthopaedic and Sports Medicine Hospital Doha, Qatar, gives a global perspective on cartilage regeneration in a coffee break with Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Takao Shima, and this is ONtheGo, the podcast all around orthoregeneration.
So I'm joined here with Emmanuel Papacostas from Greece. We're here at the ISAKOS conference.
You can call me Manos.
Manos Papacostas from Greece. We're here at the ISAKOS Munich conference in 2025, and I'm very happy to have you on the podcast on behalf of the ON Foundation. And we usually start our podcast, because now it's already a little bit past 3, with how you drink your coffee. You probably maybe had already some Munich beers, but please tell me, how do you drink your coffee?
Well, I start my day normally with a double Greek coffee.
Double Greek,
which is people might argue that it's a Turkish coffee, but it's a Greek coffee. Yeah. We call it Greek coffee. It's literally the same. So I start my day with this one early in the morning without any breakfast or anything. And then several espressos by the day.
During the day.
Yeah, today by far we are in Bavaria, we're in Munich, but trust me, no alcohol yet.
Yeah.
But a couple of espressos, which is, and there is no time. You said something about 3 o'clock. Eh? No, it's not time. Yeah. A coffee is always a good option all time, all day long, and even in the night after a good dinner.
Mm-hmm. And for our listeners, what is a Greek coffee?
A Greek coffee is a grained coffee, which is kind of coming from coffee beans, mm-hmm. But it is how to say? It is distilled in made in a pot.
Yeah.
So you kind of boil it, mm-hmm. before you put it in your
extra strong.
Yeah, in a cup. It's strong. It's strong. I wouldn't say that, at least in my standards, it's not stronger than espresso. No, but these are my choices.
All right, well, sounds amazing. I think I still have to taste Greek coffee once in my life for sure in the future. Mm-hmm. And now a little bit about your background, because already mentioned in the introduction, you grew up in Greece and now you're based in Aspetar. Could you tell our listeners how that journey went?
Yeah, okay. So I'm now in Doha. I live in Doha. I work for Aspetar, which is Orthopaedic and Sports Medicine Hospital, mm-hmm. dedicated in sports injuries, and we're dealing with athletes. But I started, as you said, my journey back from Greece. I'm originally Greek. I grew up in Greece. I was born, raised, grew up, studied medicine, did my residency program there, some fellowships abroad. My connection, let's say, to sports starts from very early age, which was when I was 11, 12 years old. So I happened to win a local competition in athletics, and then together with my studies in the high school, before getting admitted in the Aristotle University of Thessaloniki Medical School, I was competing in a relatively high level in athletics. Yep. And I continued, of course, as a medical student as well. So until my last 6th year of medical school, I was a decent athlete, committed at least. So for me, in my mind, everything was very well put together and connected. So sports and medicine was connected. It was sports orthopedics for me. So this is why I chose to go to orthopedics, and I chose to deal with that. And then when I started practicing, I was practicing on that, being team physician, being a consultant for athletes, for teams as well, and federations. And then all of a sudden, I came up to the opportunity of being in Aspetar, which for me was the mecca of orthopedics, sports orthopedics, or Jerusalem, call it as you want.
Yeah.
But for me, it's a place for someone to go. So when I had this opportunity, of course, I moved from 15 years in private practice back in Thessaloniki.
Mm-hmm.
I moved in the footprint of Mountain Olympus.
Yeah.
I moved to Middle East and Doha, and I found my new place there.
And for how long have you been there now?
I'm 5.5 years, yeah. Now.
5.5 years, yeah.
Yeah.
And how do you like it there? And what's different from Greece?
Many things are different, but the essence is the same. In terms of medicine, in terms of providing services, you try to do your best anyway. So regardless of where you are, the resources sometimes are different. In Doha, in Aspetar especially, we have the luxury of having all innovative and high-end technology, and the approach sometimes is different. And what is different apart from that is the social part, which is I would say a little bit underestimated. I mean, the social part, the life in Doha, in Qatar especially, is super for me, for my family as well. It's exceptional. So we live there with no issues, super safe, very well organized. A little bit hot, honestly. I mean, well, yeah, okay.
Hotter than
but
Greece.
Don't forget, I'm from Greece. So, yeah, and yeah, in the northern part of Greece is not that hot, but can become hot. In the southern part, where you spend your holidays, it's always more or less the same. So, yeah, the life in Doha is very nice from all aspects, but professionally is another level.
Mm-hmm.
Yeah.
And I think I also, correct me if I'm wrong, but I read on the ICRS website that you're also currently doing a PhD. If I'm correct?
I can correct you on that,
please
because people will listen and will think differently. No, I started literally, when I was back home.
Yeah. I
started my PhD on my favorite subject, which is the cartilage injuries.
Yeah.
But I decided at some point with Professor Michalis Handes, we decided to stop it because I didn't have the commitment on this. But this does not mean that I don't have a commitment on research. And PhD is very important for people to understand and to do it.
Mm-hmm.
But being a good clinical practitioner and being a good clinical doctor doesn't necessarily mean that you don't do research and you don't disseminate your results and your ideas. So for me, it's in our DNA. We have to be researchers in a way, and we have to give and pass the information to our peers, to the next generation, and we have to play a role of being mentors. The mentorship thing is quite important. So yes, unfortunately, for some reasons, I didn't manage to finish up this. But although I'm not very academic as others, I find myself a little bit more practical, to be honest.
Yeah.
But I follow, of course, the standards of academia on this.
And I think you mentioned your favorite subject already, cartilage injuries, mainly of the knee, if I'm correct. Could you tell the listeners a little bit more, maybe myself also a little bit more, on your current research projects on that, or where you want to go in the next 10-15 years?
Yeah, we are. I started already many years back with already as a physician, as a surgeon in Greece, with autologous chondrocyte implantation for large cartilage defects, with Macy at that point. But moving forward, at some point, maybe the story, you're a little bit young, so you don't know all the details, but the story of regulatory issues, and then they moved away, so we didn't have the chance to really do things as we did before. And then all this innovation coming in, and this exciting field of biologics in general, but orthobiologics in specific. And this is where we are working, and we are building our research on this.
Mm-hmm.
We are doing a lot of stuff on the the PRP applications. We're doing a lot of stuff on the stem cells, and we are launching, hopefully very soon, a very big project in Aspetar. But on the surgical point of view, I would say I'm more interested to move into the one-stage cartilage implantation. So moving a little bit away from the two-stage, which is the golden standard in large lesions. I think with certain additions and some improvements, I think we are very good on, we will be in the next years, will be very good to support our patients with one-stage solutions, which include, for sure, they have to include cells, chondrocytes. Otherwise, no, it doesn't work. I mean, if you want to build a house, you have to provide the cement, the water, and the worker. You cannot do it without the basic elements. So chondrocytes need to be there, but everything which regenerates or helps the regeneration or enhances, augments, any kind of orthobiologics, we have to see what is working and where. This is exactly where we're moving. I think we're moving towards one stage for cartilage defects, but of course there are a lot of things to understand still. Subchondral bone, the unit, the environment, the responders, the non-responders, so many things.
I think there's many details that you mentioned that I want to react on, but maybe you can lift a little bit of some interesting there with the big project that you're launching. If you cannot spill any details on that, I have a different question, but there's something that you mentioned. You'll be launching a very big project, right?
We are launching a project that has to do with a lab that will start working on stem cell technology with expansion, obviously, but as a center, and I would say as a center of excellence and joint preservation center that we are literally building up. We will try to explore all the other possibilities on that field, which is the medicinal signaling cells, the stem cells, either one stage or expanded, different sources, maybe allogenic, and all these are part of our idea of how we need to provide services. But again, on the surgical applications, I don't think that this can happen without the chondrocytes. And this is why the experience so far says that, and there are some groups that are working on this already with very good results. We have some results already published on that, and I think that the future is going towards there.
And you mentioned specifically that you're building towards a one-stage procedure, and I think that's also what I found. You're building a CAR-T1 technology project.
Yeah,
right?
this technology is already existing for many years. It was launched years back with. It's literally a freshly isolated chondrocytes on the spot on the surgical, the day of the surgery. I mean, you just provide pieces of cartilage to the back table where you have a portable GMP facility, let's say, under the laminar flow, a portable lab inside, and the technicians that they freshly isolate the chondrocytes, literally the pericellular matrix, so chondrons, and mix it with bone marrow stem cells that you get on the spot as well. So it takes, in our hands, in our technology now with CAR-T1, you take like an extra 1 hour, 15 minutes, 1 hour, 30 minutes possibly, to get the final result, which is the a dilution of a combination of chondrocytes, chondrons, with autologous bone marrow stem cells. So this combination, it is already proved by late Arnold Kaplan that if you have a certain percentage of both, then what the stem cells are doing are pushing the chondrocytes to do their job. So it's literally the signaling that they are transferring. Now there are some similar technologies with juvenile allogenic that they show very good clinical results as well. We do have there are a couple of publications over the CAR-T1 with the previous scaffold used, the Instruct, if I'm not wrong, concept, which was a different scaffold, 3D printed. But later on, and we published something with the hyaluron-based membrane. We use also collagen membrane, and we are in the process of gathering up everything and going forward to show the world what is going on. Clinically, the results are good. I can say anecdotally that maybe can be comparable to the two-stage chondrocyte implantation with cultured chondrocytes, but still there are many ways to go. Long road to go, because it's not easy. You know better than me. It's not easy to build double-blinded, controlled studies on speaking about human subjects. Maybe speaking about patients. So, and there is always some bias somewhere. But if you follow up, that's my philosophy. If you do what you feel that you need to do and you're safe to do, and then you follow closely a big number of patients for a long time, then I think you're not jumping into conclusions. You're giving some idea, and then possibly later on something more robust can come.
And that's something that you recently published in the JCGP, what you mentioned there with the hyaluronic scaffold. Just taking a step forward, because the podcast is also supposed to look to the future of orthoregeneration. Where do you think that the current initiatives that you're taking is gonna take our patients or the clinicians in like 20 years with regards to knee cartilage injuries? Where do we think we stand?
I think we are moving towards a road that we might end up like injecting something, or with a very minimally invasive kind of very small camera scope. So you not only inject but maybe deliver the scaffold or the gel that you have with the cells that they do the job, augmented by any kind of orthobiologics. I don't know if this is gonna be allogenic, juvenile, or it's gonna be umbilical cord or blood, or if it's gonna be autologous or same family. I don't know exactly for sure. I don't think there are many ideas on this, but I strongly believe that we're gonna come to a point that we will deliver to these defects something. But we have to always remember and have in as a first priority all we're talking about now, future and biologics and everything. We have to go back to the basics. So listen to the patient, see what are his needs and expectations, deal with major things like meniscal insufficiency or absence, alignment, stability. These are the basics. We are moving and we're thinking about the detail, but sometimes we're losing the forest.
The bigger
picture. We have to, and we know that osteotomy, for example, can give you a very good clinical result for a quite long period for these kind of patients. But my feeling is that, if you are a cartilage surgeon, which in my opinion needs to be a specific subspecialty of orthopedics, you have to deal with the joint preservation in general. So you have to deal with the homeostasis, which is metabolic, which is chemical, which is mechanical, anatomical. So you have to know what to do, and you have to go and do it. And you pick your weapons, but you have to not to disregard the problems of the joint itself, or the whole milieu of products that we have there. So many people are doing the osteotomy and keep it there. It's okay. For some time, yes, but we don't know if we really intervene on doing something on the cartilage, on the defect, on subchondral bone at the same time. We unload it, plays a role, but possibly we can do something extra. So that's my point. We have to think coming back to the basics, evaluate the patient, and keep up with his expectations, and his needs. It's a different story if you're talking about a professional athlete and you have a professional athlete who wants to play in the National League final that played yesterday, and he came like 3 months ago with a cartilage defect. You're not gonna do a very complicated procedure for him. It's another story, but you have to provide the options.
So if I'm trying to distill the answers that you just gave, it's already in 10 to 20 years, it's still important to keep the whole basic aspect, of keep the bigger picture of the milieu, the most important factors that are not only the specific details, but just the whole bigger picture of the patient.
Correct.
And then
to see, in my opinion, to see the forest, not to focus on a tree only.
Yeah.
So it's a holistic approach. Yeah. So it's as Jari said, it's the homeostasis.
Yeah. Do you think that, because I think that's an interesting way to think about it, but the forest and just one tree, which is maybe one specific injection or whatever. Do you think when walking around on these conferences and when you look in the literature, we focusing too much on only that tree?
Yeah, I agree. We oversimplify things because we came in a situation that we think, or in some cases we do, we reached our, our basic level of safety on everything, and then we move to the detail.
Yeah.
It's like it's the luxury thing. But if you don't have a real car to drive you there, and you just need an expensive car to do something, or an addition in this car, then you're not gonna go there. You can go there also by bike, depends on the distance. So you have to stay on the basics, remember always the basic stuff, and try to do some additions on the details.
Yeah. And I think that also is a good advice, because slowly going towards the end of the podcast, this maybe brings us also to giving advice to younger listeners, because the listeners are mainly young scientists, young surgeons, young doctors, having followed your path from Greece to Doha, with that vision of the whole forest instead of just that one tree. What would be your main advice, or maybe top 3 advice that you would give to a young scientist or young doctor?
First of all, to translate. So what I was always lacking, and this is what I try to get to my first of all my children, and then the fellows or the residents that we have, or younger peers that they are close by, is that you have to learn things on the other side. So if you are a clinician, you have to be also a scientist. Not a perfect scientist, but you have to know the basics. And if you are a scientist, you have to understand what the clinician needs. So this translation, this collaboration between the two major parts, we're talking about always orthobiologics and joint preservation, but it's literally basic science and clinical point of view.
Yeah.
So my basic advice would be, try to be on the other side. Keep your legs on both ends of the river, so both boats, whatever is the expression. So and try to understand the basics from each category. And the other thing is that you have to think broader. And don't disregard the basics and the things that we learn in the first years of residency. These are the basics. Maybe if you ask me about 3, So
yeah, but go ahead.
The third one most probably would be like to choose your the people that they will guide you, and the centers that you get the information from.
Yeah.
So it's not always the ones that they are fancier, or the ones that they have better social exposure or academic exposure. So you have to trust your other colleagues by giving you information from their own experience before you choose where to go and do increase your own experience.
All right, I think that those are three very good tips for young scientists and young surgeons that are listening to our podcast. And thank you very much for all your insights and picking your brain. I've learned a lot about the forest and the tree. And thanks again.
Thank you, and I have to thank the foundation also, the ONtheGeneration Foundation, for giving us the floor to provide this kind of information and kind of electronic mentorship.
Yeah.
Which is a fantastic initiative. Thank you.
Awesome. Thank you very much.
This was On The Go, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening and have a great day.